So I want to talk about Sprint, and I'm going to just present some highlights from a number of the major papers that came from Sprint. And Sprint was a study of intensity versus standard blood pressure control for the prevention of dementia. Sprint is a systolic blood pressure intervention trial, and then there was the sub-trial of interest to many of us, memory and cognition in decreased hypertension, or the MIND study. These are my colleagues that did a lot of this work related to the cognition and MRI who are in Philadelphia. The Sprint study obviously involved many people around the United States. There were 102 clinics involved with the overall study, 27 clinics with 7 MRI centers for that sub-study. And the design was to examine the effect of intensive high blood pressure treatment as compared to standard treatment on various aspects of cardiovascular and cerebrovascular health. The 2 treatment arms, the standard treatment was with a goal of maintaining systolic blood pressure below 140 millimeters of mercury. This is consistent with most of the clinical guidelines in the United States. And then the intensity treatment arm was a goal of systolic blood pressure of equal to or less than 120 millimeters of mercury, or what some people call normal. The outcomes that were looked at included cardiovascular disease, all-cause mortality, kidney disease, and again, relevant to this particular group, MCI and dementia. This group, the inclusion criteria included they were 50 years or older, systolic blood pressure between 130 and 180, treated or untreated, and at least one additional cardiovascular disease. The exclusion criteria included stroke, diabetes, congestive heart failure, severe renal disease, and standing blood pressures less than 110. So this population, which included approximately 9,300 people, was on average age 67. So it's an older population. There were more males than females. There were more whites than non-whites. The 20% of the population had a high 10-year Framingham cardiovascular disease risk number, and the average systolic blood pressure at the beginning of the trial was right at 140 millimeters of mercury. This is from the initial Sprint paper, which looked at the primary outcomes of overall Sprint study, which was the primary cardiovascular outcome was a composite of myocardial infarction, acute coronary syndrome, stroke, heart failure, cardiovascular death. And this was the hazards ratio over the 5 years of the originally proposed Sprint study. And as you can see, the intensity treatment arm was associated with less hazard of the primary outcome as compared to the standard treatment. Notice there is a flattening of the response at a little more than year 4, and that's because at this time, the Data Safety Monitoring Board reviewed the results and felt that there was a significant adverse effect of the standard treatment, and therefore the treatment arms were stopped at this time. There were data collected in the non-treatment phase of the study for 8 to 9 months after that. Similar results if you look at death from any cause with a poor outcome, a lower hazard ratio with standard treatment. So this raised the suggested that for cardiac events that there was a beneficial aspect of the intensity treatment, but there was obviously kind of an immediate question. Well, is it good for the heart? Okay, but is it good for the brain? And this goes from an article by Dr. Saper, who basically said what I was taught as a medical student a very long time ago, that treating particularly older adults aggressively for hypertension was dangerous. And specifically, his comment was that the interpretation that is trumpeted in the lay press, and this was written before this paper was published, that physicians should seek to keep their patients' systolic blood pressure below 120 torr is potentially dangerous and could result in a rash of patients seeing neurologists with ischemic brain damage. Many of these patients will not present with frank cerebral infarction, but instead with cognitive impairment, falls, or dizziness, complaints that will span the spectrum of general neurology. And I think this position actually would have been the usual position of most practitioners until the past few years. In that main sprint study, they did have a look at adverse events. And in fact, in general, the adverse events were not more common in the intensity versus the standard arm, except for those related to the kidney, electrolyte abnormalities and acute kidney injury, where there was some difference between the two treatment arms. But in general, the adverse events were not as might have been of concern. Then a sub-study was part of SPRINT, and this is SPRINT Mind. And the purpose of SPRINT Mind was to test whether the adjudicated occurrence of the following conditions will be lower in the participants who are randomly assigned to the intensive treatment group as compared to those randomly assigned to the standard treatment group. And the outcome measures were all-cause probable dementia, mild cognitive impairment, or a composite of probable dementia and MCI. And cognitive data was collected every 2 years during the trial. So this was just a timeline of it, but basically it was intended to be a 4-year study with multiple cognitive examinations during the time. The study was stopped, as we previously said, here at year 4. Follow-up was continued after that. And so there is a treatment phase time period and then a post-treatment phase observational period to the study. This is what blood pressure actually did during the trial. And in fact, the intensive treatment arm showed a projected and persistent decrease in blood pressure from the initial average of 139 actually down to the target 120 for most of the trial and cohort phase. The cohort phase, that is after the treatment trial was stopped, saw a increase in systolic blood pressure with the absence of the intensive treatment arm during this phase. Cognitive testing was performed with a screening battery of MoCA digit symbol coding test and logical memory. Those who performed at a low level on those tests were then given the more extended cognitive tests that are listed here. The adjudication obviously was critical to this, adjudicating MCI and probable dementia. We won't belabor the details, but there was a very careful adjudication of the cognitive test in conjunction with the other examinations of the patient. For MCI, in summary, they had to have that diagnosis made by adjudication 2 times, not 1 time, 2 times during the study. And this is the basic result from the cognitive portion of the SPRINT Mind test. In terms of probable dementia, there was not a significant difference between the 2 arms, but for MCI and a composite mild cognitive impairment and probable dementia, there was a difference in the 2 arm with an advantage to the intensive treatment arm. Again, this is suggesting that not only may there not be any harm from the more aggressive blood pressure treatment, but there might be some benefit. Looking at subgroups into the effects of the intensive treatment arm, in essentially all the major subgroups, there were no statistically significant difference between the subgroups. In general, the intensive treatment arm was related to superior outcomes. Then finally, Sprint Mind was incorporated into the study. Sprint Mind MRI, this was a study to investigate basically the effect of intensive blood pressure treatment on structural measures of the brain. This study included, as you'll see in a moment, initially 600 with approximately 450 follow-up patients with MRI. The hypothesis was that the intensive treatment results in a slower increase in white matter lesion volumes and less brain volume loss than standard treatment. The primary outcome measurements were whole brain, white matter lesion volume, and total brain volume. There were initially 673 subjects enrolled into the MRI study, again at 7 different MRI facilities. 454 subjects had the follow-up MRI that passed quality control, and so the primary analysis was done on 454 subjects. This is the blood pressure results through the trial with the anticipated reduction, lower blood pressure in the intensive treatment at the 120 millimeter target. There's a shorter observation period of the MRI cohort after stopping the treatment arms. This was due to the fact that the MRI cohort actually started a little bit later than the overall Sprint cohort. Image processing was done in-house with an automated pipeline. It involved many of the usual MRI quantitative analysis processing procedures, histogram normalization, bias field correction, multi-atlas segmentation, template registration, and white matter lesions were segmented using an in-house automated tool from T1, T2, and FLAIR images. Subjects with major structural lesions were excluded from the analysis. The primary MRI results are shown here. The white matter lesion volume on average increased in the intensive treatment arm, almost 1 cc, 0.92 cc's, versus the standard treatment arm, which was almost 1.5 cc's, 1.45. Because of the skewness of the distribution of white matter lesions, the primary analysis was done with the transformed white matter lesion volumes, again showing a smaller increase in the intensive treatment arm at a statistically significant level. So intensive treatment related to less increase in white matter lesion volume over the treatment time. Total brain volume, there was a decrease of approximately 30 cc's in the intensive treatment arm versus a smaller decrease in the standard treatment arm. And this was likewise statistically significant. Looking at the subgroups, in terms of white matter lesion volume, there was no significant difference in any of the subgroups in terms of the relationship to the treatment arm and cognition. On the brain volume subgroups, there was a significant difference in sex, with the intensive treatment having a better outcome, associated with a better outcome in women, and the opposite with men. So in conclusions, it's that progression of white matter lesion can be slowed by intensive management of hypertension, and this in a relatively elderly population who actually have had hypertension for over 10 years. There is a small decrease in total brain volume between the treatment arms, probably clinically insignificant, but obviously I'm not being terribly objective and hedging bets on that right now during this presentation. But white matter lesion volumes and total brain volumes show no convincing evidence of significant brain injury. Some implications: intensive blood pressure control is the first randomized clinical trial intervention to show a reduction in the risk of MCI in a population such as this. And there's no evidence that intensive blood pressure control harms brain structure or function. And these are acknowledgments, particularly to the 9,361 volunteers who participated and the various NIH institutions that funded the study. And appreciate the opportunity to present this to y'all, and happy to take any questions.